Good evening, classmates and professor. My name is Johanna Bana, and I'm going to present to you my project about enhancing seater utilization at Kaiser Permanente. KP is a non-profit integrated healthcare system combining a health plan with direct care delivery through physicians, hospitals, and medical facilities. Its model focuses on value-based care, aiming to deliver high-quality health outcomes while managing cost. KP has a regional seater policy that does not align with local policy, causing confusion among managers about which one to activate. The local seater policy has not been revised since 2023 and needs to be reviewed for possible revision at the following quality meeting. KP uses many seaters daily, particularly on the ICU and adult med-surg ward. Its fall rate remains constant this year and last year, resulting in a substantial financial impact even after adopting virtual seaters. Not to mention, the seater responsibilities do not indicate role clarity, considering the unit employs many nurses as the seater itself. Local policies suggest that a care technician can take vital signs, while regional policy does not specify the assignment. And if a nurse is assigned as a seater, what responsibilities can she perform? And if local policy is retained, algorithms must indicate when to refer to the KP seater policy. Virtual seaters must also be equipped with the latest technology, incorporating AI-powered strategies to maximize their effectiveness, as well as other technologies that enhance patient safety. The significant cost and risk associated with these incidents, combined with a healthcare environment of limited resources, prompt the facility to improve fall prevention safety interventions. A patient safety assistant or a seater is the most prevalent method to address falls and other behavioral events in inpatient settings, but not necessarily the most effective. They are often used in the inpatient to ensure the patient safety of patients and staff. However, an estimated 700 to 1 million hospitalized patients fall each year, spending $34 billion annually, with patients 65 and older alone. At the hospital level, fall injury costs range from $7 to $30,000. One third of these falls are preventable. Quality gaps also require further improvement to identify variants and enhance care coordination and patient care. According to Greeley et al., one-to-one seaters are used daily to prevent falls and manage violent behavior. However, their effectiveness has not been definitely proven. Eliminating the seater is not supported either, and other measures must be considered to implement more effective and proven safety measures. Virtual seaters, VS, monitored by a technician, are increasingly popular as an option to minimize in-person costs under appropriate clinical indications. Due to the risk of HIPAA compliance, care coordination are still sourced within the company. Likewise, VS lacks best practices and implementation strategies, necessitating further evaluation to optimize its availability in nursing managed care. This project aims to review the current seater policy, utilization, and procedures at Kaiser Permanente Auckland to increase our knowledge and improve processes utilizing comprehensive, intercollaborative, and evidence-based strategies. KP Auckland Richmond is an integrated unit that functions as one, monitoring seater costs and functionality to ensure its appropriateness and impact on the organization. Although L&D rarely uses seaters, the number of seaters utilized at KP Auckland is high, and it calls for review to see where the company can streamline its process. The project aims to enhance patient safety by focusing on fall risk and sentinel events, improving patient experience through comfort and innovative care coordination, and it will also optimize available resources by utilizing in-person and virtual seaters with proposed strategies and enhance the algorithm if possible. Here are the possible project outcomes. First, consider using a violence risk assessment from admission, especially when readmitted, to plan care pathways and collaborate with other disciplines. The team must collaborate to provide resources to direct staff members with limited time and insufficient training for managing psychiatric patients. Incorporate a psychiatric liaison nurse or patient attendant that are proactive in managing high-risk patients instead of assigning registered nurses to sit. Cluster 2 to 4 patients according to risk assessment score and evaluates the need more often than every 4 hours. Second, more straightforward guidelines should be created for nurses, LPNs, PCTs, and PAs, aligning with regional policy. Customize the care plan with frontline involvement based on the SHIP assessment by the sitter and other disciplines visiting the patient. Indicate daily active and passive patient activities designed to monitor and observe behaviors and physical abilities necessary to make critical and ethical decision making. Make proactive intentional rounds, especially when utilizing a virtual sitter more frequently. Incorporate the decision algorithm with tip sheets on medication review practices, activities, patient and family education, involvement, signage, and the use of non-skid kits during rounds. Additionally, SBAR should be utilized during endorsement to have a structured nursing care plan and documentation. Third, the use of technology can be maximized through continuous vision monitoring, classifying patients based on full risk assessment, and allowing VT to accommodate up to 12 patients instead of 6. Technology adoption must be done through nurse enculturation, data tracking, management, and patient family feedback. It is a safe alternative, but it requires implementation strategies that involve nursing integration with a well-trained VT. Fourth, leaders' involvement is a key strategy in developing a sense of commitment to fall safety improvement. It is a key to fostering a culture of safety that shows improved adherence to fall strategy programs, resulting in enhanced fall outcomes sustained over time. KP is positioned to address theater utilization pathways by innovating quality improvement structures and guidance for enhancing fall prevention programs by supporting QI projects like mine, and provide consistent training and education to strengthen employees' understanding of the CETR pathways, continued evaluation, and equip them with the skills to manage complex patients. According to NSO, this multidimensional approach encompasses sustained cultural change, enabling leaders and enacting frontline staff and refining team practices. A QI project can achieve its desired outcomes with supportive leaders, engaged frontline staff, and collaborative interdisciplinary efforts while innovating EBP across all disciplines. This approach will not only cut costs but sustain its safety culture. The plan aims to inform and engage stakeholders, manage expectations, facilitate feedback, and ensure the project success through a solid communication plan to enable them to adapt to changes. The clinical staff, who are the primary users, are key to the project success. Their feedback is crucial for identifying challenges and ensuring the virtual system integrates seamlessly into existing workflows. VT must also be incorporated into the communication protocols, and their skills and perspectives must be taken into consideration. Meanwhile, unit leaders oversee the implementation of their specific units, manage staffing, and reinforce policies and procedures for using virtual theaters. Patient and families are vital in all phases of the project. Their perspective is essential for assessing the impact and overall experience as indicated by KP's survey upon discharge. Family or caregivers can provide valuable input on their loved one's care and may find reassurance in knowing that constant monitoring is in place. Lastly, the hospital executives who approve the project aligned with the hospital's broader patient safety and cost-saving strategies and authorize the necessary budget and resources. The Nurse Council and Quality Safety Team play a critical role in assessing and tracking the impact of virtual seaters on patient safety metrics, particularly fall rates. IT and security ensure the technical readiness, connectivity, security, and integration of the virtual monitoring system with other hospital systems. Even if the project has not been implemented yet, you must bring them together early to gain buy-in, clarify roles and expectations, address any feedback or concerns, and build ownership for successful implementation and sustainability. The most important thing at this point is that the Nurse Council recognizes the gap and is open to enhancing the CETR algorithm. Once the project receives approval, the most effective implementation strategy is to utilize the PDSA cycle. We can proceed with planning after identifying the stakeholders and obtaining their buy-in. The problems identified early on in the project goals are all part of the planning phase. In addition, all evidence-based strategies proven to optimize cost while delivering equal or improved quality outcomes should be gathered. Develop an action plan that outlines communication channels and timelines, roles and responsibilities, resources required for the test, and the specific unit for the initial implementation. Next is executing the plan, incorporating ABP strategies and virtual assistants. Provide the training procedures to the staff, including virtual tech, while nurse leaders evaluate how the new policy is implemented and gather feedback. Then in the study phase, data will be collected and analyzed to measure the impact using quantitative and qualitative feedback. Finally, in the act phase, decide whether to standardize the change, modify the plan for another test, or abandon the idea based on the study results. This bottom-up approach increases the likelihood of adopting the changes, a key requirement for successful QI. The team will also utilize the CFIR to identify barriers to the project's implementation and assess existing structures and procedures. It is a framework particularly well suited to this evaluation, given its ability to identify key barriers and facilitators of implementation from the perspective of multiple stakeholders. To accomplish its aim, it must have the right team with the right skill set to thoroughly examine the psychological, physical, and procedural barriers it faces. Identifying its domains and contracts support rapid cycle evaluation of healthcare service implementation and produces actionable findings intended to improve implementation promptly. The team must continue to solicit feedback post-implementation to ensure sustainability by regularly communicating outcomes and utilizing data to facilitate ongoing evaluation by stakeholders. Healthcare is dynamic and may need to adjust goals when new barriers emerge while maintaining patient safety and operational efficiency. A hospital can still ensure safe and effective handoffs by using established communication techniques and implementing ad hoc best practices. The key is standardizing individual and unit level processes by focusing on clear communication, verification, and accountability. While the project needs further review for approval, adopt a proven communication framework to ensure no critical information is missed. The transfer of information should be concise yet thorough, with the opportunity to ask clarifying questions and confirm key details. A handoff tool can effectively transfer responsibility and accountability for patients' care. Develop a handoff checklist and components based on the needs of the QI team. Consider completing this activity with other team members and discussing how the team could utilize this checklist. Once the checklist has been created, try to adjust it to ensure it captures all key elements without being too complicated or time-consuming during face-to-face communication, thereby communicating the stakeholder communication plan to guide information exchange between a project and its stakeholders. Ensure the blueprint for when, how, and what to communicate to ensure all parties understand the project's trajectory and role within it. They should also allow questions that may enable the receiver to clarify key information or to call attention to issues that might have been overlooked. For patient-related matters, the team can utilize SBAR to communicate the patient's situation and background, enabling the team to develop a plan based to enhance theater utilization pathways. The project helped me cultivate my nursing competencies as a healthcare leader. AONL emphasizes the pillars of an effective leader by owning all of them through experience and knowledge advancement. Understanding the spectrum of nursing rules and leadership is the most effective way to achieve this. Continued practice and practicum experience are great activities for future and current leaders. The quality project taught me how to improve quality and process by familiarizing myself with the phases, including data analysis and variance identification using different EBP models, theories, and frameworks for continually evaluating healthcare practice. It calls for continued evaluation, education, training, and more straightforward guidelines for its stakeholders to support. Russell et al. Emphasized the importance of our role in cultivating the culture of EBP implementation and sustainability. Our position empowers us to influence current nursing practice and our colleagues by being proactive and encouraging their voices to have a seat at the table for policy making, quality and process improvement, safety, and nursing provisions. If we continue to work as a team by engaging in activities like this and all other care practices, we can sustain and strengthen the culture of safety and empowerment. Innovative nursing practices can reduce hospital seater usage and cost as a component of a patient's focused safety plan. KP must continue to evaluate its seater utilization pathways, and with the transition to virtual and enhanced strategies using evidence-based, nursing-driven approach, the organization supports continuous improvement through innovative EBP practices. But it is easier to push one when you are already an employee. However, it helped me cultivate my nursing competencies as a healthcare leader. Understanding the spectrum of nursing roles and leadership is the most effective way to achieve this. Being proactive and committed to our profession must allow us to further advocate for QI projects like this, allow nurses to participate in refining their skills and innovating their strategies by familiarizing themselves with the bases, including data analysis and variance identification, and utilizing various EBP models, theories, and frameworks to evaluate healthcare practices continually. It calls for continued evaluation, education, training, and more straightforward guidelines for its stakeholders to support. Even the best ideas need buy-in. The last slide indicate the references I have used for this project. I hope you enjoyed my presentation. Have a wonderful night. Thank you.